live with another episode. It's been a few weeks. You're rusty. You usually bring us in.
Well, you want me to start over here?
No, I want you to give us the.
Hey, everybody! Welcome to the Vitality Code podcast. I'm your host, Dr. Jason Farrah. Across from me is my well-bearded, handsome younger brother, Dr. Jeffery Farrah. The beard's coming back. I'm happy to see that.
It's looking good. I don't remember how long it's been, but it was
slowly but surely.
December, so we're looking at 3 months. I said 6, so it's starting to look nice.
Yeah, I know it's coming back because you go from the acceptable kind of well-shorn business appearance to the more craggy woodsman lumberjack. And then when you eventually reach the survivalist stage, the Ted Kaczynski survivalist stage, Unabomber stage, then I know, okay, now he's finally there. He's finally back.
Is that a nurse practitioner in the room, or is that a homeless man?
I only say that out of jealousy. I wish I could grow such a delightful facial aesthetic as you have.
Yes.
Did you catch any of the State of the Union address last night?
I'm still on my political detox, so no, I didn't even know it was happening.
You're trying to cut back.
I'm trying to cut back on my consumption of the insanity. But I did find out this morning as I was perusing some internet websites that it did happen. So was there anything of substance that I need to know?
No. A bunch of
his enemies are terrible. He's amazing, and everything's great.
Yeah, I mean, hey, Joe, you made it. Let's see. They definitely gave Biden one of those.
I honestly have said this to somebody, like, whatever they give him to bring him from Sleepy Joe to, like, the Joe of old, I want some of that.
Dude, I don't know. It's a Provigil, a Ritalin. It's a amphetamine. I don't know what it is.
They're hyping him up on some amphetamines for sure.
Oh, I'm sure. Well,
I mean, an 81-year-old.
When your 8-year-old nephew flexes his muscles at you, let's see this.
Hey, ooh.
Oh, sweet Joe.
A MAGA hat. Some of them wore a MAGA hat.
Yeah. That's why I took him by surprise. Oh, it's Marjorie Greene of all people.
Is that who it was?
Oh gosh, one of his arch nemesis.
I love that little bit. I don't remember who did it about wearing the MAGA hat.
Yeah, there was a lot of that last night. There was a lot of shaking of the head.
But just like
wow.
I think it was the comedian's bit was like, the people who wore the MAGA hat are just choosing violence for the day. It's the last thing they put on before they walked out of the house. They were just, this is the day it's going to be. I'm setting the tone for the day. I'm putting on my MAGA hat.
You are, man. You are inviting some, yeah. Dude, you talk about inviting, yeah.
There's got to be a lot of MAGA support, I would imagine, in Myrtle Beach, right? And my thoughts, I mean, I have no idea.
Straight, boy. Damn straight, boy. This is a dirty South, boy. What you talking about? Hell yeah. America.
Is it really?
America.
90%.
90, baby. This is MAGA country, boy. You go down the intercoastal waterway, and there's definitely signs literally says MAGA country. There's a truck in town.
We've talked about this.
Yeah, flags
and everything. I love it, man. I wish at some point I had enough faith and belief in somebody else to get behind that cause. I don't know anybody that would fly their flag. I don't fly. Nothing. Never. Who? I've never seen anybody in my life that I would fly a flag for anybody at any point in my life.
I gotta say, like one of the last people that I can remember in recorded history. Now, I'm not some kind of historical guru, but I remember even Dad talking about this. Sweet Lou, and everybody during this generation. It must have been amazing, but JFK was one of those guys. JFK.
Yeah, you think polarized? Well, when you hear
wait. No, hold on a second. I mean, inspirational. I didn't mean
inspirational.
Polarizing.
Did I say polarizing?
Yeah, I mean,
I misspoke.
Maybe he was, but no, inspirational. Like
brought together everybody.
Yeah, and
that's the thing never of my generation. I've never seen a politician bring anybody together.
The cool thing about JFK was, he was a Democrat, which is fine, whatever, and he was a liberal, which is also fine, but he was classically liberal. So he wasn't woke, he wasn't progressive, he was liberal, right? So I always think of that as somebody's reaching for new ideals and the greater good. The greater good, reaching new ideals. The human species is reaching a new plateau. Hopefully, maybe we can be socially liberal and fiscally conservative. We can be reasonable. We're somewhere in the middle.
Humans aren't good at that, man. It's all or nothing, brother.
Well, it is. It goes in cycles, and so
We're going to swing back the other way, and that's what scares me the most.
Yeah, well, it's always been like that in recorded history. This is the fourth turning, right? They call it. Have you ever read that book about the turnings? There's these.
I don't think so.
Cycles that generations go through, and then you have this crazy woke, crazy leftist, I guess for lack of a better word. That like way extreme. Like there is extreme right, MAGA, and then there's extreme left, and then
Is that Kennedy there?
Yeah, look at that. Look at that.
I mean, think about
man. Amazing.
Think about RFK now. Like his uncle was assassinated, his dad was assassinated. That's gotta be some. That's gotta be some
shit there, man. That's some weird.
shit, right? Too much about the reality of how government works. When your uncle and father were both assassinated in the political figures, man,
I wonder he became a heroin addict.
And just imagine the distrust and the knowledge of things that he probably knows that, I mean, it's wild.
What a juxtaposition to be in, right? Is he still running? I mean, is he still running for, okay.
Can you imagine him and Biden debating for the Democratic?
Oh my God.
Democratic nominee. That'd be wild.
Yeah, it's tough, man. His poor voice. I mean,
his voice, but his brain is on fire.
Oh, it's on. Oh no, absolutely. I agree. He's a very interesting.
So speaking of brain on fire, let's get to some testosterone stuff. So I want to just step away from, I think, a little bit from the optimal. I was talking to somebody, and we're just inundated with the optimal and the protocol and the science and the 27% versus the 29% and this research study and this, but I don't see much
values
practical.
Of less than 0.005.
Yes. And at some point I'm just tired of it. I'm like, yeah, have you seen a patient? Whoever you are that's telling me this research study says this, and you should take this for this many minutes and this many times, and you should stare at the sun, and that's all good, and we need that, but like I need some practical advice, and I think patients need some practical information. So I wanted to kind of hit some quick practical topics of testosterone therapy. So I wrote down a few. And these are some specific things that I'm dealing with in the clinic the past 2 weeks. And so I just wanted to kind of banter back and forth on that a little bit.
I mean, I think, any plan, what do they say? Any plan for war is good until you hit the first minute of the battle or whatever. I don't know.
It's a terrible paraphrase, but yes.
Terribly paraphrasing, but well, give it a go, my friend. You know the quote. You're just as bad.
I'm the worst. That's why it makes me happy.
Mixed metaphors and
whatever. Everyone's got a plan until you get punched in the face. I think that was Mike Tyson.
There you go. That's a good one. Yeah, that's exactly right. Right. What really works on the boots on the ground basis.
So I want to talk to you specifically about blood pressure. The first one's blood pressure. So let's talk about these kind of broad topics in no particular order, but can you get testosterone if you have blood pressure that's elevated above optimal but not controlled? If you have high blood pressure but is controlled with medication and no longer high? And what are the implications for taking testosterone does it raise your blood pressure? And if it does, what is an acceptable level, and then how do you handle those kind of things? Those are the things that I have a specific patient that's dealing with, and he's diving way down deep into the optimal and the protocols, and he's researching on his own, quote unquote, and he's getting quite frustrated. So first and foremost, does testosterone elevate blood pressure?
It can. It's been implicated in it. As we've discussed on this study, it's a vascular hormone, just like estrogen. So there's the effect it has on vascular beds is generally thought to maybe increase blood pressure. I would think, if you polled 10 internists or just 10 physicians in general, the truth of the story, at least biochemically in vitro studies, is much, much different, right? And blood pressure and vascular reactivity is a huge, massive topic that, we could do a whole couple podcasts on, right? Starling's forces, ionic, the forces with the salts in the blood, and then you talk about the aging blood vessel and systemic vascular resistance and how it becomes inelastic with age and different things. But if you want a healthy blood vessel based on biochemical murine models and in vitro studies, you want to have good testosterone. So to me, you want nitric oxide, you want healthy endothelium, you want laminar flow through your blood vessels, and testosterone promotes that. However, it matters at what level your serum testosterone, to me, and what I see in the clinic, what level your serum testosterone reaches, how quickly it reaches it, what carrier and how you're administering it and how quickly it gets in your body. And a lot of that to me has to do with, in my expert opinion, is the conversion to estrogen and the hypertensive effects of estrogen. Think
Okay.
about a pregnant woman, right? When you talk about preeclampsia, right? Hypertension is obviously part and parcel to that diagnosis, or even like, in a more down the road, down the sequence, like HELP syndrome and things, and the effects of the kidneys and the bad effects of hypertension. You don't see that those women are having massive increases in testosterone in their body during those times that I am aware of, although there could be obviously increases in testosterone above basal rates, but we do see big increases in estrogen and progesterone. So with that increases, you tend to increase retention of salt and volume, increasing blood volume. Right now, testosterone could increase your blood volume by androgen-induced erythrocytosis, and
Well,
that
that's what I
will.
was going to go. Is that? But so, can we? What would you say the practical number is? Like 20 points, 50 points, like out of control? Is there any data that you know? As to
Boy,
specificity, like how much
I'd
it
have to.
raises them?
No,
The
I
most
mean
common ones I see are like 6 to 10 points on your systolic.
6 to 10. But what does that translate to anybody on testosterone anytime?
Well, so the one study that I remember specifically was they took no, it was 6 to 10 above baseline was the most. I can't remember the details. Was the most common rise above baseline for people taking testosterone, and then
Systolic
those
or diastolic?
systolic,
Hmm.
and then those with an subsequent increase in um, hematocrit were more likely to experience a 10% or 10-point jump. So that these authors suggested that the more significant increase in testosterone increase in blood pressure due to testosterone was likely tied to raises in your hematocrit.
Hmm. So how do you approach that in the clinic?
Well, good question. So first thing I tell patients is, and I say this about a lot of things, is I don't, and we don't approach this scared, but we also don't put our head in the sand and ignore that. Like, oh, there's no rise in blood pressure, and we also don't say, like, well, it could raise your blood pressure, so I'm super scared, I'm not going to do anything, right? We take practical measures and we try to reduce the likelihood of things happening. So first and foremost is measuring the blood pressure. That's a good thing to do, and then making sure you're managing your estrogen, making sure it's not leading to increases in volume, just water retention, and then managing your hemoglobin hematocrit. I have found that testosterone, I classify it generally with my patients, not a risky substance, but it's a higher management substance. And I just that's how I classify it. There's a little bit more management than you're used to, and there's a little bit more management that I'm going to expect of you than if your primary care wrote you a blood pressure lisinopril. He's just going to write you a year. Oh, look, it lowered your blood pressure, and then your scripts from here on out. But testosterone doesn't fall that way. We're going to check more periodically. We're going to dial it in a little bit more tight. We're going to find your specific estrogen or anti-estrogen dose. We're going to find your specific testosterone dose. So there's a little more management, i.e. a little more involvement on your part if you do injectables, and there's a little more on my part if we're doing pellets.
So, see, to me, it's tough because it's such a multivariate. It's the causality of hypertension is so multivariate in nature. In other words, if you see people with idiopathic hypertension or essential hypertension, rather, excuse me, and and you've got and these are just people in general population. There's 100 people. It's not as though the people with hypertension uniformly have high testosterone levels. So de novo endogenous normal, high endogenous testosterone levels don't equate to that. Although maybe there's some genetic counter-regulatory mechanisms in those people that do that take away from that, and people that don't have those, for instance. But it is glucose intake has a massive role in it. I mean, glucose is a far more, not far more, but it's a very, it may be, I don't know exactly, but it's a very potent volume. It has a very strong ionic pull. In other words, a charge and bringing water into the vascular space, so it can raise blood pressure quite significantly. So glucose homeostasis plays a big role. Salt plays a big role. Your body mass index and your the extra body weight you carry on your body, and so it gets tough to narrow down to one thing for me. And I try to look at the patient holistically and view them from all the different angles that may be affecting their blood pressure. So with that in mind, if testosterone is going to raise it 6 to 10 above baseline systolic, hematocrit. Now, when you say for a rise in hematocrit, you get a 10-point jump. You're talking about anything above 54?
I don't remember the cutoff they used, but those who had rises in hematocrit, and they gave a percentage in the study, and I don't remember the percentage, but those who had an X percentage jump in hematocrit were more likely to fall into the people who saw a jump of 10 points.
Okay, I would say so. So let's say somebody comes in and they start
saying that maybe it wasn't testosterone, maybe it was actually the rise in hematocrit that led to the elevation of blood pressure.
Absolutely, and the effect on the kidney that we talked about, specifically the effect in the kidney that we talked about in a previous podcast. But so if somebody comes in, they start out with a hematocrit of maybe 48, and they start testosterone cypionate, and they're at about a cc a week at this point. 3 months in, their hematocrit rises to 52, and they went from 132 on their initial systolic blood pressure to now 142. What do you do?
Depends on their estrogen, depends on their level of
Estrogen
management.
is 20.
Yeah, so my first stop on management is to check their estrogen. My second stop is that I want to know if they're on blood pressure meds. Have they ever had an issue with this? What are their risk factors? And then if I'm specifically managing this, I'm probably going to recommend a lower dose. If we're trying to bring it down, I'm going to probably recommend a lower dose if that seems appropriate before I recommend phlebotomy to lower the hematocrit.
So even though the hematocrit's not at above the 54 threshold, you'll still recommend phlebotomy?
No, I would not recommend phlebotomy.
Oh, okay.
But usually what I tell people is like, we need to deal with these things, right? And so I honestly probably would, at 142, I'd probably wait and watch and make sure that that's appropriate and an accurate reading if it's just a one-time reading in the office. And then I would, exclude all other factors.
How would you do that? How would you implement this monitoring or whatever?
Repeat testing. Did you take any Red Bulls this morning? Did you drink coffee? What's your caffeine intake? And let's retest it, and maybe some home monitoring. And then I would have that patient come back and recheck it and get some more information. Was this 142 just an off number? Were you drinking 5 Red Bulls today? Whatever it may be. And then typically I will lower dose depending on how they feel and their response and their subjective and objective measures. Probably I would choose the lower dose before I went to other measures.
Yeah. Okay. So would you advocate for a blood pressure journal? Do they keep it home, or
yes?
Would you just okay?
Yeah, with an in-office reading. I don't do any. I do manual blood pressure readings. I don't do machines.
So the basics, lifestyle choices: avoid stimulants. So monitoring, keep a blood pressure journal. Lifestyle choices: avoid stimulants. Mindfulness and stress regulation, and also looking at their body weight too and body habitus.
I think first I would back it all the way up and I would talk about the importance. Like I think a lot of my clients are just like, yeah, it's cool. It's 142 over 92 or whatever the number you said, and they're just like, yeah, whatever. And I'm like,
it's always been high. It's always been high.
That's my favorite one.
I can't stand that. Yeah.
I'm like, well, now it's a bigger problem. So it's been high for 20 years now, not just 1 year. So it's actually a bigger problem that has been high
Right.
forever.
Yeah.
Um,
People
so
seem to
my
be
first,
reassured by that,
yes,
but they don't realize that, their blood pressure can be a disease of acuity, hypertensive crisis,
correct.
urgency, or emergency, or more often it's a disease of chronicity. And so those additive effects over years, and instead of reassuring you, it should actually make you more scared.
The first person that ever said it to me was a person that I knew. He's like, "Oh man, we went to high school together. He was a little older than me, but he's like, yeah, man, it's been high since high school. When we did our football physicals, it was always high then." I'm like, "Well, that's worse, brother. You're in your 40s now. That was back when you were 18. That's we got 20 years now on you."
Did his last name start with N?
Yes,
Yeah, I
yes.
know exactly who you're talking about. Yeah.
So, yeah. So that's, I think I want to stress the importance of proper blood pressure. And I tell patients, you worry about how you feel right now. You can tell me how the response is in the 6 weeks of testosterone. I want to look 10 years down the road. That's what you're paying me for. You're paying me to have a broader lens, look down the road more, to keep you healthy, to keep you feeling good at 75, not make you feel good for the next year on testosterone, right? This is something that we should be doing. And part of that is managing your blood pressure and making sure the testosterone is not making it worse, and we're not doing you a disservice. It may not be the testosterone at all, but there's ways to, if it is, mitigate it, and there's ways to make sure that it's properly done so that it doesn't.
Let me ask you a question. Do you find that people come into your clinic because sometimes it gets a little bit tough? You have a primary care, classically trained family physician, internist, and then people that are trained in primary care, and then people that aren't, and they're physicians or other types of allied health practitioners. But when you go to a TRT clinic, quote unquote, sometimes it's weird because you're in a silo. Like, okay, T low, I fix. Okay, like number low,
Sure.
I fixed it. So, and they think that way too. And then the patient may think that, the practitioner may think that, or they might think the opposite too. So I'm wondering, like, how do you have people that come in that they're maybe unhealthy in other areas of their life, obese, sedentary, any number of other things, diabetes, any other chronic maladies and lifestyle issues, but they do have a low testosterone, and then they want you to fix that, but they're not so interested in fixing the other things. Number one is, do you find that a lot?
I don't think I find the disinterested. I find those two run together. I find my clientele is more interested commonly in that. And it may be because I tell patients that I don't advertise, I do word of mouth. So if you come to me and you came to me because you just felt crappy and your doc told you had diabetes and this sort of thing, and you were getting out of shape and fat, and and you came and had a good response and I addressed all those, you're likely to refer similar people to you. And so my clinic has started to become made up of a more similar type of person, and that more similar type of person is someone who's interested in all those things, as opposed to
So
just
you're
interested
saying
in
the way you set up the practice and the way in which you practice attracts a certain clientele, or a certain set of patients, and those patients attract patients like themselves to your practice.
Because specifically, I had this realization because I don't advertise. So there's no Google ad where you click on, you're like, oh, I want testosterone replacement. So you're going to hear about my clinic from somebody, and that person tends to hang out with people similar to them. So they're like, hey, you got to go check this guy out. He really helped me, and he helped me, get back in the gym and manage my diabetes and manage my blood pressure. And so they tend to refer similar patients.
Right.
Versus, I imagine if I had set it up a different way, and not all my patients are that way. So I definitely have those divisions where, but they tend to refer people like them. I'm like, oh, how'd you find my clinic? Oh, it was Bob. And I know how Bob is. And that sort of gives me some inference how this person will be probably.
But you do have a spectrum. And so people on the other end of the
Yes.
spectrum could, invite or refer people like themselves.
100%.
I guess what I'm saying is this is a really good topic, actually. I'm glad you brought it up, because wellness, the healthcare system in general, it's not that we don't have avenues to achieve and pursue wellness, taking advantage of practitioners' knowledges and clinics that are set up to such, but they're not as organized as those to set up and manage chronic diseases.
Correct.
Or or acute diseases. So you have a hospital for acute diseases, and you have a lot of outpatient clinics for chronic diseases. But those are managing diseases, and those are important. And putting Band-Aids on them, because bandaging wounds is important. But finding out the root cause of the wound from a first principle standard is not difficult to understand. Maybe not even difficult to sell cognitively, but very difficult to execute on and implement in a clinic.
Yeah, it's not hard up here; it's hard down here.
Right. Well, that's part of it, and then also when you've got a primary care doctor who's seeing thousands of patients
Impossible.
in a week, how can they? And they don't have. You can sit here and criticize them all you want, which I would not, but
I wouldn't want their job.
It's a very, very tough job, and they know they want to help, but it's just literally the bandwidth. I mean, how much can you really do? So when I see somebody like that, that's why this question throws me a little bit for a loop, but it's a good loop, meaning when somebody comes in and they have high blood pressure, I have to go back to first principles, and yes, the testosterone can be a problem, but if the testosterone causes a 10-point systolic blood pressure elevation in a person who has weight to lose, has excess body weight, is not eating right, has hyperglycemia or some level of glucose homeostasis dysregulation, I mean, am I going to just automatically lower the dose? Am I just automatically prescribe an ACE or a calcium channel blocker? So I get a little bit worried about putting those Band-Aids on, but at the same time, those people that come in, it's hard too. You serve in this role as a practitioner to rectify their hypogonadism, but it's much more than that. You have to take the person as a whole, and you have to realize, I guess that's your point, is that you tell them right from the get-go, this may occur, and when and if it occurs, we'll take it step by step, and we'll approach it from the different angles, I guess is what you're saying, from the different facets that cause it. Because just scaling back the dose, or just getting a phlebotomy. Now, if that's the problem, I get it, if the hematocrit's high, but I find that it usually comes with other things. If it's a problem, It usually comes with other things. And sometimes it's pre-existing, sometimes like it's lifestyle.
Patients don't want to I always ask the patient, what do you want to do about this? I ask them, I'll just be blunt. I'm like, do you want a medication? I want to deal with it. Do you want a medication? Do you want a lifestyle? Do you want a dose change? Something like that,
Let me tell you something. This is interesting. I had a guy very much like this exact scenario, and I was so proud of the store. I was so proud of the PCP. Not that he needed me to be proud, but I was proud of the PCP, the guy's PCP, when he came back with the story. And the PCP said, look, I can prescribe you a medication. I know exactly what medication, and I can lower your blood pressure, maybe even a couple of medications. I'll do that if you're not interested in lifestyle changes. What you need is weight loss, diet, and exercise, and lifestyle changes.
Do you need that? Now we're going down but I don't know. Is it for me to decide that patient needs that? Is it not your right as an autonomous human being? I don't want to go existential, and we're going down rabbit holes here, but isn't it my right as a patient and as an individual to say, I don't want those things. I want a medication?
Yeah, of course it is. But I'm saying, if you go to a person who has knowledge for a certain malady, I have high blood pressure, or I want to be well, identify in me those things that are unwell, and provide me ways with which to correct them, which is the implied contractual proposition when you go see a doctor, right?
Mm-hmm.
Either implied or.
But the word need. You need these things. You need diet and exercise.
Well, okay. You need diet and exercise if you want to correct your blood pressure.
Without medication.
Or I can give you a medication and put the Band-Aid on. Yeah. But it was pretty cool. He said, the guy was, this speaks to your point. Just give me a second. The guy was very much saying the autonomous, he's like, but I'm not going to tell you what to do. Mm-hmm. You tell me what you're willing to do. And if you're not at a point where you're willing to consider diet and exercise and be very, it's tough. You got to really be disciplined. If you're not willing to do those things, then perhaps we need to go down the route where you take medication, and that's fine too. You tell me what you're willing. Right. So I guess it's kind of what you're saying, and I was very proud. There was autonomy. There was recognition of what the underlying first principles problem was from a physiologic standpoint. There was an acknowledgement of, I can give you a Band-Aid, which is a medication, and I can change the number, which I need to do for your long-term health, which will benefit you should you want to make yourself available of that. Which would you like to do? Autonomy. Yeah. So does that speak to the issue that you're talking about?
Yes. Yes.
It's nuanced, right? I mean, I know it's subtle.
I think it's a lot harder. The thing as I more step into a primary care role, I think primary care is really difficult to do. And not only the science of it, but dealing with patient care is really difficult. If we want better outcomes, it takes a lot longer interactions to do that. And it's not going to happen. And the problem is the doctor, the problem is the patient, and the problem is the system. It's not only one of it's you can't.
Yeah, that's a good
You
point.
can't walk into a doctor who has thousands of patients, who has 10 minutes with you, and expect him to spend 20 minutes with you. And
Right.
you can't give somebody advice.
And you can't expect him to be not human either. He or she not human, right?
And you can't have a shitty insurance and expect them to care about you and
Right.
pay for 45 minutes of that doctor's time. And you
Right.
can't expect me, who's not willing to do any work, to then badmouth both of those people for only
Right.
giving me 10 minutes and the doctor writing a script. Like, we're all equally contributing to this. And so
We're all implicated. Yeah, we're all culpable. Yeah.
yeah. And so I have found it to be exceptionally hard with time with a patient. I need a lot of time with patients to not do the simple thing, which is write a prescription.
Right. So what I'm saying is, when I see these people come into the clinic, I know that I'm going to fix this number, but I have to prepare myself and be thinking. And you can't, as best I've seen, you can't really put all that on a patient at once, because you'll overwhelm them and frankly scare them away and not.
That's the art of practicing.
That's the art. That's the art.
But that takes a lot of time. A lot of time.
But sometimes that time is a linear temporal relationship, meaning it's not
Correct.
just that, and you have to look at it as that.
It's not an hour. It's like, lots of visits over the next 2 years, right? Is that what you mean?
Yeah, and I think you can blame the system sometimes, and because if you look at how family medicine was originally created and what it's supposed to be, and I went to Florida State University College of Medicine, and they were trying to do something back then and create this primary care model, and so we did a lot of research and a lot of learning into the way. Now, I ultimately went into a specialty, obviously, but in my basic medical school education, there was a lot of didactic training and group training and clinical training on the origins of family medicine, the relationship you build as a practitioner with patients. And that's how it was initially tended to be. But the system doesn't allow for it. And let's not just blame the system. Nobody, in terms of the practitioners, has been able to buck or make that commitment to do anything different.
You're not going to change the
or
system.
here and there. Right. So you have to change yourself.
You have to practice. That's the decision I made. I can't change the system. When I did my preceptor work, I said, this is a giant system that's moving and practicing a certain way. I don't choose to participate in this for the benefit of my own personal health and what I see as a benefit of my patients. So I'm going to choose to practice outside of that.
Right.
And I think the way you change it is more and more physicians step out of that model, and more patients seek those physicians. You can't go to a physician and be like, I want you to spend lots of time and put lots of emotion and put lots of care into me, but I want to pay you what Medicare pays you. Those two don't go together.
I know exactly.
If you want to use your Blue Cross, if you want to use your Medicare, and they pay your chiropractor $19 to adjust you, you're going to get a 5-minute visit. If you want someone to sit down, diagnose, talk about the ins and outs of your back pain, try a bunch of different things, then we need to have a different system. So you can't.
Because what happened was the physicians, practitioners, and allied healthcare providers of all kinds, unbeknownst or complicit, and the patients are complicit. That's exactly what you're describing.
Yeah.
And that there was a system created by non-physicians and non-patients, non-practitioners and non-patients that was, and I get it, you're looking at a whole country, right? You're trying to provide basic level of healthcare for a whole country. So I'm going to criticize them, but also recognize it's very difficult. And then you're looking at people that are bean counters. I hate to say that. And they're looking at, and they have to be though, right? Somebody's got to look at the books, but looking at it from blood pressure, high blood pressure, you need to prescribe these medications. How can we get them cheaper? But wait a second, it's so much more than just these medications, But
Okay.
you're right. You got to step out. You got to step
All right.
outside of
We
that.
gotta pause that issue, and we gotta move on to one more before we get talking too long.
So I think in conclusion, you gotta acknowledge it. And I don't just go right to me personally. I try to look for the other things that could be contributing before as so long as the benefit from the testosterone is there. Yes, I start with the estrogen, I start with the other things, then lifestyle factors, but I try to look at other confounding or contributing factors before I just knee jerk. And I'm not saying you do that, but I'm saying, but one could do that. Knee jerk, lower the testosterone or get rid of it.
Sure. All right. Fertility issues. I want to talk about fertility issues. Does testosterone reduce your fertility? Yes or no?
Yes.
And how does it do that? Does it make you impotent?
No, it shouldn't. I mean, that doesn't
Correct.
make any, that doesn't
Yeah,
make any
it
sense.
makes sense, right? So it lowers your intratesticular testosterone, which then lowers your sperm count. That's
Your
kind of what I tell patients.
hypothalamus, it talks to your pituitary, then talks to your testes, right? So FSH and LH from the pituitary, FSH to set up the environment, support the Sertoli cells, and indirectly the Leydig cells. You're right. LH to support the Leydig cells, increase the intratesticular testosterone such that maturation of sperm is promoted, and ultimately you can produce viable sperm. If the if exogenous administration of testosterone is incurred, you'll increase the negative feedback signal to the brain, which will lower the stimulus to the testes, thus decreasing intratesticular testosterone, decreasing FSH and Sertoli cell support. And yes, you'll become something less than, however fertile you were, you'll be something less than
That's
that.
a good way to say it. Something less than where you are right now.
Right,
before you start.
Who knows? Yeah, you might have some viable sperm. It's not like you'll be, azoospermia or you might be oligospermia. Yeah.
And I tell people on the flip side of this, because I heard this and I didn't realize it before I started, is that it's not birth control. It's not effective means of birth control. Like I think in some bro science circles, there is this thought, I'm on testosterone, I can't get anybody pregnant. And that is not true.
That's true. It's not. But interestingly, it has been looked at for that reason.
Oh,
and I only point that
as a means.
Oh yeah, like in China, there's studies absolutely suggesting that maybe we do that for birth control. I mean, it's funny because you think about female oral contraceptives.
Mm-hmm.
These are
It's
synthetic.
Exactly
yeah, it's the same.
I always found it funny that you weren't allowed to give a young man testosterone because one of the big reasons you weren't quote unquote allowed to because it messed up their fertility. But I was allowed to give a young woman estrogen to mess with her fertility.
Look at that. Bam. That's 2019. Good job, Nick. Excellent. Producer Nick. That is fantastic. Yeah, testosterone. Wow, that by the way, as an aside, if you want to get something published, those titles are great. Even if your study suggests it doesn't prove, that's controversial, right? Testosterone is a contraceptive and should not be used in men who desire fertility. I agree with that concept, and I guess I would say this, Jeff. Again, it's all in the nuance, and it's all between the lines. All of this. There you go. Yep, GnRH, Sertoli later. Exactly. That's just exactly what I just said. Scroll down a little bit. Intratesticular. Yep. Look at that. You know what? I like that graphic. Will you send me that link, Nick? Producer Nick.
It's a good one to explain to patients. I'm a big visual learner too.
And maybe you could even link it into the show notes if anybody. It's very interesting. Very good job. Excellent, producer Nick. Send me that link too if you wouldn't mind. So I would say on the contrary, it is contraception, not classically defined, but it is contraception. Let's think about it this way.
I see. I think I know where you're going.
Okay, yeah, because like let's say birth control. Can you get pregnant on birth control? Yeah. Are you less likely and significantly less likely to be? Yeah. So bro science, there are shades of truth, and that's the problem with bro science, right? It is contraceptive, but is it effective contraceptive? Well, it depends on how you define effective. If it reduces your fertility by 75%, that's statistically significant. I don't just from a one-time number.
Sure.
I mean, I'm not. But would we consider that effective? Well, if we're talking about the analog in women, you're talking about in the high 90s. So
right. I guess that's how I just tell guys, like, in a practical sense, don't think of this as birth control.
No, they shouldn't. I
If
mean,
you don't want a child, you should continue
safe
to practice
sex.
the same practices that you're doing now that's gotten you
Right.
this far, or if you are at all. But okay,
Right.
so what if I am a young guy, which I'm seeing more and more and more, and we don't want to go down that rabbit hole, why that's happening, but
God,
young guys in their 20s and 30s, testosterone in the 200s, want testosterone, but also want to protect their fertility. What do you advise them? Don't do it. Do it a certain way, in a practical sense.
That's a very tough conversation to have, and it takes time and it's nuanced. The easy answer is don't do it, but you have to contrast that, juxtapose that against the benefits of doing it, and that would need for that I would need it would be a case by case basis. Like how low is their testosterone? What are they?
But in
what are
a
they suffering
global
from?
scale, right? So I tell guys, like, this depends on your risk tolerance, your desire to change the state you're in, and your desire to protect your fertility. And here's the safest, here's the next safest, here's the least safest, here's
Degrees of risk. Yeah.
degrees of risk. And so I say, really, I'm going to lay these out, and it's kind of a general term, but let's talk about your risk tolerance and your desire. Do you have one kid and maybe you'd like a second one? Do you have no kids and you definitely want a
Right.
big family? Do you have 3 kids and you could care less? And if it happens, it happens, maybe the 4th, so there's a lot that goes into it. But so excluding those factors, do you think you could speak to maybe some of those levels?
Yeah. So let me say this. I think if you open up a textbook of andrology, urology, or some kind of TRT guide, the generally accepted or generally used thing, and this is so vague though, and it's so general, and this is some of the problem with this field or medicine in general, but they might they're going to put you on HCG, right? So this is an LH analog.
Until the FDA screwed that up.
Right. So it's LH analog to stimulate the Leydig cells and increase intratesticular testosterone and maintain some amount of fertility. And the thought is that if a man wants to preserve testicular size, volume of the testicles from aesthetic standpoint or what have you, and somewhat their fertility, and even, and I hear guys online and social media talk about this too, the ejaculate, that being important, like the volume of ejaculate. It's like from a porn standpoint or what this is, but wanting to keep maintain. But I mean,
I think it has some correlation to satisfaction with sex and climax.
Well, for sure. I mean, yeah, I'm not denigrating it, but it just, when you say it out loud,
it is an odd way to say it.
It is, right? So it generally low dose HCG. I've seen protocols in the 500 to IUs or 1,000 IUs 3 times weekly, every other day. But the problem with that is the clinical endpoint, right? I don't know. Is somebody looking at their testicles and saying everything's okay?
I tell guys,
somebody looking at their ejaculate and saying their cum shot's okay. You can't measure LH because it's being suppressed, and HCG is not LH. There's not a good, useful way to measure intratesticular testosterone in the clinical patient.
And this is why I think practical advice is so important. Like, what do you see in the clinic, doc? So I tell, if you have very low risk tolerance to testosterone, but you still want to do it, let's do a sperm count before.
Yes.
Let's run a protocol and do sperm count while you're on it. And I don't find many guys. I have had people take me up on that, but they don't generally want to do that. But some do. And again, I tell people, it's not my decision to tell you how nervous about this you should be. My role is to tell you what I see, what the likelihood is, and then you see where your risk tolerance fits into that. And so that is one way to do it. And I find most people don't do that, though.
I would say that's the most comprehensive way. That's the most but that takes that that requires discipline and suppression of instant gratification. When you come into a clinic, I have a problem. I want to get the problem solved. I go to McDonald's.
Test is not the easiest to get done.
No.
I mean, from practical standpoint, not every lab does it. Only certain labs do it. You got to get a sample there in less than 30 minutes. They're like, I live 45 minutes from the clinic. I'm like, you'll figure it out.
Right.
I've heard every story in the book.
Oh, I'm sure. Behind a Walmart, and
don't do that. Don't do that. Don't do that.
But the doc told me I was only officer.
I've heard car. I heard friend's house. I had a friend's house. Can I use your bathroom? I was like, oh, that's weird.
That's a friend. Okay. That's a friend. Hey, I'm there for you, man.
So what's the
Um,
next one below that? Like, is there an acceptable dose? If someone wants to preserve, say they're 25, they don't have children, and they want to do testosterone, do you practically prescribe HCG to run simultaneously?
I don't like to do it, but I will do it
Why don't you like to?
because it's so imprecise, and I don't
Mm-hmm.
like. I don't like stimulating things to grow or promote their function that I'm not in control of from a genetic standpoint. Meaning,
Yeah,
the body has a genetic code, and it's embedded, and it's there. And I get worried if I'm, and the only reason, and that's kind of a vague worry.
You mean stimulating the brain?
Well, no, because you're not stimulating the brain; you're stimulating the testes. I worry about stimulating the testes, and I don't,
Hmm.
because I don't know. I don't even know if I don't even know if an LH. Well, there probably is an LH secreting tumor. There must be an LH secreting tumor. But I mean, like what are the implications of just constantly of stimulating the Leydig cells, which
Hmm.
are constantly stimulated, I guess, throughout your lifetime, but in a way that your genetic code determines and knows. I Who knows? Like how do you know? Like, does anybody know how long you can be
Would you
on
say
HCG? And
Yeah, I've seen long-term studies, and the last one I saw was years.
like how
Without,
many? 1 year, 2 year,
I
3 year,
think it
4
was
year? I mean,
three. Was the study I saw.
but even that, I mean, that's just like,
I agree.
and then how many people, how many patients were in the study? 20,
Yeah,
100? I mean, like how many? I mean,
there you go.
yeah,
There's some.
gonadotropin and secret adenomas. Yeah, I knew there was. I just,
So, what would you tell somebody that if they're nervous and they wanted to take precautions, as many precautions as they could, but still take testosterone? Would you say that that is a way to potentially minimize risk?
what's a way to minimize risk?
Taking HCG continuously while you're doing it.
Minimize risk of infertility.
Fertility, yeah,
Yeah, I think well, it absolutely is. I don't know how much it minimizes it,
right.
and like the only way to know is exactly what you said: sperm count before, during, and then I guess you could say after as well. I would say this in general. So here's another nuanced thing too. If you don't have a varicocele, if you don't have a mechanical problem, if you don't have, if you don't have an undescended testicle, if you don't have common, I'm thinking of common reasons for infertility as a man. Okay, um, if you don't have any kind of genetic mutations, alterations, if you don't have a mechanical problem, i.e., a varicocele and blood flow issues, if you don't have an undescended testicle or some other kind of issue, and you're normal genetically, and it's also a timeline issue. Like, you can be on testosterone, come off of it, recover, and become fertile again, quote unquote. So maybe that's a better route. If it depends, are they married? Are they not married? Are they planning a family right now? Are they not planning a family right now?
Let me
Is it
tell
how?
you. Yeah, here's what I
So
tell patients.
it's really individual. It's on a case by case basis. I will do it, but I want to try to avoid the least impact, the least amount of harm to accrue to the patient that I can, recognizing and having that mental checklist of going through things that cause infertility. Do you have those or not? Okay, you're fertile. And then I like your idea of the sperm count before and during, but just to blindly put somebody on HCG and say, yeah, you're fine. I'm not a big fan of that.
Yeah,
How
here's
do you?
what I tell my patients in a succinct, like if I'm talking to an actual patient, I say the fertility issue is an issue. Let's talk about that. We talk about whether or not they want children, they have children, all that kind of stuff. In terms of options, what I tell them is if you have concern and that concern is of great enough importance that you thinking that you don't want to do it, don't do it. Right? That's the
Right.
safest. That's the safest one. Below that, I say if we're still going to give a nod to risk tolerance, but our symptoms are bad enough, we want to get on it. We can do testosterone. Make sure our dose is managed properly. We're not taking synthetics. We're not being silly, and we're going to run a certain level of HCG or Clomid during your testosterone treatment. And that could look like something like HCG continuously, or that could look like running testosterone for a certain amount of time, doing a break after a certain number of length, and doing a test to see how your body responds. I tell them my rationale behind that is like, I want to see how your body's going to respond to coming off testosterone, how you feel, what that looks like, how long it takes to recover. So you have some inkling into the future of what that may look like. Let's
I
run that before it's
I,
an issue.
I like that. Let me give you a protocol that I use. Okay.
And then
I'm
lastly, hold on. Well,
Go ahead.
lastly, my other option is you run testosterone, and when it comes time that you and your spouse or girlfriend or partner, however you want to classify them, are going to stop protecting, which is usually the first, I think the general first stop on having a baby is you're not trying, but you're just stopping protection. At that point, let me know, and we will start adding. We'll lower your dose and add some HCG or Clomid at that time.
I like that.
And I tell them it's a factor of, we're going to lower your dose, we're going to add some HCG, and it's a sliding scale. We may have to keep lowering the test, keep adding the
Yes.
HCG, keep adding the test, and we may come to a point where you have to come off testosterone completely, and you may have to go on a larger amount of HCG, and that may be where you end up. It may not be, because it's a sliding scale. So that's how I address it.
I like that. I do something similar. I've been hedging in this conversation because it's a topic that it's so individual, but let me tell you how I do it. So first, I break down is I say, is this person testosterone / anabolic androgenic steroid naive or not? Okay, so let's go in the case of it. I've never used androgenic anabolic steroids, and I've never used TRT. I'm naive to it. I have I'm a wild type hypogonadal, right? Like it just occurred for whatever reason. It wasn't because of exogenous use.
Wild type?
Yeah, wild type. Just, existing in the wild, you know. It's a genetic.
I've never heard that term. You
never
wild
heard
testicles.
No, that's you never did genetics of the fruit flies, the wild type. You know, like it's just
yes,
it's just naturally occurring. That's a
Gotcha.
known genetic term, wild type. Okay, so they're naive. They've never been on HCG, never been on Clomid. They've never been on anything, and they just have and they're hypogonadal. And then so that's A. So that's the first algorithm step. Okay, so let's go to the right of the diagram, whatever, arrow down. Now, is your fertility desire imminent or protracted? Meaning, do you want this in the next year? Okay, so if you are in the next year and you're hypogonadal and you're naive to all these medicines, let's just forego TRT altogether. The goal is to raise your testosterone, right?
Let's just feel better.
Well, but how? Right?
I know. I'm just
okay, right. You're right. The goal is to feel better.
So your goal is to raise your testosterone. Go.
Yeah. Yeah, we're not going to just do meditation to feel better. We're going to okay. So if that's the case, I'm just going to let's consider this. Maybe I just make you super fertile and raise your testosterone by means of Clomid and HCG plus or minus, or HCG plus or minus Clomid, or vice versa. For instance, there's a lot of good data, small numbers, but well-constructed design studies and good reports out of the Mayo Clinic using, and all other places, and a lot of other places too, but using Clomid and just Clomid to raise testosterone. So you're not going to decrease fertility. You're going to increase testosterone and increase fertility. The problem is, are they going to be a responder to the Clomid or not? Are they going to respond to the HCG or not? And if you're not responding to either one of those, then fertility might be a problem for you anyway. So most people are going to respond to one or both of them, right? So if they're naive and they have imminent desire for fertility, then let's not do TRT at all. Let's do HCG and Clomid. Let's set a time frame on it. I think the sperm samples are still good. Now, if you're a person who's not naive, what have you used? Is your testosterone low because you've suppressed it with exogenous testosterone use? How long? How likely? And then is your desire imminent? So I kind of break it down that way and go down that road. Let me give you an example. I had a guy who has an imminent desire for fertility. And then again, it's on a case-by-case basis. I have a guy recently seen in clinic who has an imminent desire for fertility as a past user of TRT and androgenic and anabolic steroids, and got married, told his bride-to-be, this is the deal, right? Has no varicoceles on exam, has no history of undescended testicle, and as best he knows, is fertile. Told his now wife, prior to them getting married, hey, I'm just letting you know, heads up, I was on this, I'm willing to get off, or I have been off, or whatever. Disclosed it, in other words. I know we want to have kids. It may be an issue, it may not. I don't know. Okay. I love you so much. We're getting married. Okay, now I want to have kids. Okay, it's an issue. 3 months down the road, no one's getting pregnant. 4 months, 5 months. Okay, let's go get a sperm sample. Oh, by the way, in the meantime, got off everything, just cold turkey. So is miserable, dragging, has no desire for sex. So that's a problem, right? If you're trying to get somebody pregnant, no desire, and is hypogonadal with testosterone low 200s, went and got tested and has oligospermia. So he's got swimmers, quote unquote. He's got viable sperm, but just a low count. What do you do with that person, right? So, and this is why it's on a case-by-case basis. Now, that's somebody who, to me, after a thorough discussion of all the different benefits and risks and options, and this is described in the urology literature, and I've spoken to urologists about this in certain cases and so forth, that's somebody who you can concomitantly, you can consider concomitantly putting on TRT and HCG. So I'm going to, because so profound is their hypogonadism that they don't even have this desire for sex, right? I mean, cognitively maybe, but they just physiologically can't respond to it. And they're suffering with motivation, low energy, dysthymia. I mean, holy cow! Like, look, this marriage is not going to survive if you don't have an intimate relationship. So and you're suffering at work. You're suffering from a mental. Okay, so look, we got to now. So low dose testosterone to at least get you into some kind of optimized range compared to where you are now, and then concomitantly raising your intratesticular testosterone and increasing fertility with subsequent sperm testing and dialing, like you said, from there with testosterone doses and HCG. So to me, the first step is, are they naive or not? And then going down that algorithm on a case-by-case basis, that helps me determine, because I may not even need to use TRT to raise the testosterone. Make sense?
Yeah, which I do a lot to some of my younger patients and different protocols. Mm-hmm. Yeah, it's very nuanced. Well, Doc, I appreciate your time this morning, man. It's good talking testosterone with you.
We'll have to do some more common.
Yeah, I got some more that we need to talk about. So yeah, I think one of the things I want to do is some guys that are coming to clinic and coming off. I did some stuff when I was younger, and I want to come off and make sure I'm safe. And those are some topics I want to dive into.
Okay, yeah, absolutely. We kind of touched on that a little bit, but yeah, let's go dive further in that. So today we covered blood pressure and fertility. We'll cover something another time. Awesome, man. Good seeing you.
Good seeing you, brother.